Alberta DCD community of practice, and I hope that this session finds you all in good health. We had seriously considered canceling the session given the possible Skype overload mostly, but also given the uncertainty and often the anxiety-provoking environment that we all find ourselves in. However, many of us have had a significant decline in client visits, so maybe even have a bit of time on our hands, and we thought that this would allow us to experience a little bit of some level of normalcy. We hope that the technology holds together today. Just one very quick update. Our Central Zone DCD resource team is looking for a couple of AHS, OTs, and PTs from across the province to join us in creating standardized services for DCD. We hope that we will also receive approval to complete a multidisciplinary clinical practice guide in the future. So if you're interested, contact me and we can discuss what the time commitment looks like and the approval process that you need to get before moving forward. Okay, so let's move to our presenter. If everyone could please mute their mics. It's very distracting for our speakers if there's a lot of background noise. So we'd appreciate that. Thanks so much. So it's with great pleasure that I have the privilege of introducing Karen Hurtubise. Karen is an experienced clinician, program coordinator, and manager in pediatric rehab. All of Karen's studies and training have all focused on improving access to care and decreasing the burden of care for youth with chronic conditions and their families. Her research interests include exploring family-centeredness of pediatric rehab services, the rehab experience of youth and parents, parent learning, and rehabilitation program development, implementation, and evaluation. Karen completed a Bachelor of Science in Physio at the University of Ottawa, a Master's of Rehab at UBC, and is currently just finishing her doctorate in health science research at the University of Sherbrooke. Her thesis focuses on evaluating rehabilitation interventions, their outcomes, and impact on youth and their parents. She's also currently a clinical instructor at the University of British Columbia in their online program. Today, Karen will be presenting on the therapeutic interventions for children with motor difficulties. What is the role of telerehab? This is a very timely presentation, given that many of us are now exploring telerehab as a means of meeting some of our clients' needs. Thank you, Karen, for sharing your time and your knowledge.
Well, thank you for having me. It is certainly an interesting time and a very interesting time to be talking about telerehab, which I suspect in the next little while we're going to potentially see many opportunities. And hopefully this presentation will make you feel maybe a little bit more ready for that, as well as be able to have some support, or at least know what the evidence is around some of the stuff that's out there and available. So as you all know, or what was circulated, is that what I'm hoping to share today is the evidence related to web-based platforms in pediatric rehab.
Someone needs to turn their speakers off on your computer.
This usually happens if you're on the phone and on your computer. There. Thanks.
Perfect. So what
No.
Maybe we've got it under control.
Okay, perfect. So what I'm hoping to share today with you is a bit of some of the evidence and some of the research we've done on web-based platforms in pediatric rehab in studies out of our lab that we conducted in Quebec, so Sherbrooke in particular, but also the rest of Quebec. Some of the lessons we learned around some of those platforms, and in particular some of those that are that we're currently using and involved with a current study, as well as to explore potentially some of the perceived facilitators and barriers of implementation, both what we've met up with in Quebec, and I'd like to actually have a bit of a discussion with you guys as we kind of think about this, of what are some of the facilitators and barriers on implementing telerehab for children with gross motor concerns in Alberta. So if you could switch slides for me, please. So we know that children with mild to moderate motor delays, including children with DCD, are at risk for a number of physical, social, emotional, and mental health difficulties. We know that there are many, and I know this group knows them well. And so part of what we were looking at within the group of, within this group in Quebec, but I think I can attest, having practiced across the country, that these kids, despite all the health risks, have very limited service and rarely meet the mandates in rehabilitation services, whether that's in a rehabilitation center or those associated with hospitals. Next slide, please. So we know that actually very few children with mild to moderate gross motor delay actually require tertiary care service. So as we think of it, or even, you know, the expertise of secondary care services. And in fact, maybe they go to those places because that's where the services are, not necessarily where the services should be delivered. So there's growing consensus and looking at sort of where these services are delivered, as well as the delivery model. And perhaps if we looked at a graduated staged approach or framework to organizing services for these children, they may actually be better serviced. So what if we put these services in primary care, closer to their home, in their schools, and in their community, instead of bringing them to the hospital? Would we not only increase access for services for all children who need rehabilitation services, and equally provide potentially the opportunity for children who don't get a diagnosis of mild to moderate gross motor delay, but have these delays, the opportunity to actually flourish? So that's kind of where all of this started from. That question of redesigning services in many ways. And we know in order to redesign these services and potentially bring these services closer to where these children are or live and participate, is that we need to increase education and capacity building in those environments. Not only for the children and their parents, but also for the people and stakeholders in those environments. So next slide, please. So we know already that parents have been going online looking for information for a long period of time. So when I looked back, what we wonder, or when I look back into the data, I could see research going back as far as 1997, probably when, you know, the internet was just really getting up and running, with regards to parents going to look for information. So we know they're using web-based services already. We ourselves as healthcare providers use web-based services. Teachers use web-based services. Other stakeholders use web-based services. So we had the question of, could we actually use the web or the internet to actually deliver service, to actually increase capacity and educate around these children? So next slide, please. So the journey started a while ago, and some of you who've been involved in providing the services to children and their families with developmental coordination disorder will remember some of these key points and these key times, because I know that when I was in Alberta between 2007 and 2014, I was involved in some of these projects. So the very first project around using web-based platforms was initiated by CanChild, and some of you probably still use the developmental coordination disorder module for parents, as well as the one for PTs, that CanChild produced, I would probably say sort of 2014-ish. So that module was developed by Cheryl Masuna and some of her students. It was later translated in French by Chantal Camdem and her team, who then decided to evaluate the online module with the new translation. The English translation was not evaluated, just in case you were wondering. So the French translation actually was, and the study looked at trying to examine whether an evidence-based online module could increase the perceived knowledge and skill of parents of children with DCD and lead to behavior change. So thanks to a coordinated approach with their DCD association, they were able to recruit 116 patients or parents of children with DCD. And if we go to the next slide, on the left, you'll see, one of the module pages. But on the right, you'll see what the results were of that study. So what they found was that providing targeted and accessible information is indeed an intervention that can impact families and should be looked at in any provision of service as a cost-effective solution. Particularly, changes in parents' knowledge, skills, and expectations of their children were noted. And this is only information that we're sharing with these families. It also ensured that parents' ability to make changes occurred, and this was dependent on a couple of different factors. One, the information had to have clear recommendations. What were they supposed to do with it? They had to be somewhat supportive and had to find the time to be able to try some of those recommendations. And they had to have the right attitude in applying the information and in working with their child. So that study concluded by thinking that future research was required, just like any study actually typically concludes. And there was two main areas that they wanted future research directions to head into. One was looking at whether the recommended strategies, what impact did those have on child outcomes? So we looked a lot about how it changed parents' skills, knowledge, and expectations. But what happened to the child, and what did their outcomes look like? As well as, was there a possibility, using this kind of information sharing, was there a possibility of changing societal norms? So creating environments, as I mentioned, that would foster the ability for these children to actually develop motor skills and participate more in daily life. Next slide. So the next project, and some of these projects and how they translated over time were due to different opportunities. So not always, what Chantal and her research group would have liked to tackle first, but an opportunity arose. So first we looked at an online community of practice for physiotherapists. So looking at changing that environment and seeing if we couldn't improve the ability, the knowledge, and the skills of therapists to actually provide evidence-based intervention. So the purpose of this study was to evaluate the impact of a virtual community of practice on PT's self-perceived practice and the factors that might influence changes in their knowledge, skill, behaviors, and practice. So we had 41 PTs who agreed to participate. So if we can go to the next slide, please. So what they agreed to participate in was 2 face-to-face workshops on best practices in DCD, which were held 3 months apart. In those, in between, what they had is access to an online forum where we could exchange information between PTs, and as long as you didn't name the patient, you could ask for clinical advice. And you also had access to evolving resources. So typically, whatever was coming up in the field of DCD was being posted, any tips and tricks for some patients that might have worked, any type of exercise sheets, etc., that people were finding useful were shared on the forum. So what we noted is that of the therapists, so those 41 therapists who were invited to participate, 74% actually used the virtual community of practice. 71% engaged as readers only, so only would read the postings, but didn't actually post anything. And we had 29% that actually engaged in sharing information. Those who tended to use the forum had less years of experience and were younger than those who did not use it. And we found that if we use a variety of strategies, such as having themed weeks, like, let's talk about summer camps, let's talk about how to teach bicycle riding, we increase the number of visits to the forum. So let's move to the next slide and look at the results on behavior change, knowledge, and skills. So what we found that regardless of whether you were a poster or you just read, that PTs experienced a significant increase in their self-perceived knowledge, skill, and in their confidence in using and implementing best practices. The magnitude of increase of their knowledge and skill was similar to the PT module developed by CanChild, which some of you may have helped validate and provide feedback on. However, the self-perceived confidence in using and implementing best practices was actually greater than that used in the module, of those using just the module. So the results here make us understand that potentially the interaction between the therapists on the community of practice actually was more useful in improving confidence and potentially changing behavior than just passive strategies like just delivering information. The other thing that also was interesting, in particular when we linked a number of these studies, was that it became quite evident that getting information just in time was really important to therapists and really important to improving behavior, knowledge, and skills. And so even just reading the information was actually sometimes enough to change behavior. So if we move to the next slide, we're going to get into now a little bit more of how we applied this web platforms to parents. So you'll remember the second objective of the very first, or the second direction for future research in the very first in the very first study was that we really wanted to look at, what impact did the recommendations and strategies have on child health outcomes. So we began looking at this question by testing. We wanted to test the feasibility of even considering providing service on a web-based platform. So if you'll change slides for me, please. So the purpose of this study was really to look at the feasibility of recruiting and retaining families with children suspect of having a diagnosis of DCD in a trial evaluating a web-based platform aimed to support families. So we wanted to determine whether the intervention was feasible, would families actually use a web-based platform, and explore participant satisfaction with the platform. Next slide, please. So best practices in children's rehab are really moving towards this empowerment model where we help families manage their child's condition through population-based response to intervention models using a universal design. So this may look familiar to some of you who actually potentially work in school-based therapy in Alberta because they tend to use that response to intervention model. So we're looking at providing lots of information to families and capacity building, providing equally a forum for them to exchange their own ideas before we actually get into direct intervention. So in particular, with regards to this intervention in this study, what we made available to families were resources, so including the CanChild model the CanChild module that I presented a little earlier. There was a forum that occurred between parents of various information exchanges or questions, which was moderated by an OT and was question and answer focused. They also could actually ask in a private forum questions to an OT or to a parent, and there was the possibility of doing a virtual exchange, so an actual video teleconference through WebEx with an OT. I'll give you a little bit more of what the study looked like. If we can change slides, please. So the study used a randomized design in that we had 28 participants, which met the eligibility. They were split into two groups. One group which received the intervention I just outlined, and then a control group that only received information. Okay. So we go to the next slide, please. So what did we find? So you'll remember we wanted to know whether or not it was feasible. So we wanted to see if we could recruit patients or participants, and we were able to recruit approximately 7 per month for the duration of the study. Equally, you'll remember that we wanted to look at how much they used it, were they satisfied, and their perception of the actual web-based platform. So what we saw was moderate use, moderate satisfaction, and perception of its utility. So when we looked at it quantitatively, so they filled out a number of different surveys, what we found was as the group in total, so if we looked at all the patients, there was no actual effect found in improving parent knowledge and skill. However, if we actually subdivided those who had not yet received a diagnosis or had not received treatment, what we found is the access to web-based information increased parental understanding of the impact of motor difficulties on their child's life. But what was probably most interesting was the feedback we received from the families, which I've summarized in the next slide. So the feedback we received, which was useful in setting up the latest study, was that families basically said that it was really important to have access to this information and to this type of service early in the diagnostic process. So very early when they had developmental concerns or when they were recently diagnosed. I'll just specify here that the children were ages 5 to 12, and you'll see how that's changed in our newest study based on this feedback that we received from parents. We also, parents also told us that this was an important alternative for people who potentially could not afford private in-person services, which tends to be the second line of how they access services in Quebec. They mentioned that, including scheduled appointments with a therapist or like a walk-in clinic type of being able to access a therapist one-on-one, would be an added benefit. Now, you remember in the model, they actually did have access to that, but nobody actually accessed it. So which equally illustrated to us that maybe we needed to do an orientation session on the actual platform with the families to guide them through what were the functionalities of the platform and remind them what they had access to. So if we go to the next slide, I'll share with you where we are now, which is the fourth study. So the fourth study is looking at developing an actual virtual service for families, and instead of actually saying it's specific for children with DCD diagnosis, we've really used that whole information that we received and the feedback we received from families in saying that it's really important as soon as they have early developmental concerns or they're really early in the diagnostic process. So if we move to the next slide. So this new study is called WeCare, and WeCare stands for Web-Based Early Intervention for Children with Motor Difficulties Using Multimodal Rehabilitation. That's why we call it WeCare for short. So the primary objective is to evaluate, in comparison to usual care management, the effectiveness of a web-based platform for improving children's performance on parent-identified motor function targets or goals. So what we're really looking at is, again, that research direction of what do these types of recommendations provided on a web-based platform, what impact do they have on children's health outcomes? We also wanted to look at what are the factors that influence the implementation of such interventions, and we're going to compare the trajectory of service and cost for the trial arm, which means the web-based care arm. So again, we're using a randomized model where we have a group of children who will get the intervention and a group of children who will not. So if you move to the next slide, I'll outline who we're targeting. So we are targeting parents or guardians of children 3 to 8, so you notice younger years as compared to our feasibility trial, who live in Quebec. We are looking to recruit 120 that would be eligible, so that would be at risk or suspect of motor difficulties with or without a diagnosis. And the motor difficulties are basically being screened through the little DCDQ or the DCDQ regular age. And the families are actually filling that out online, and we have an algorithm that actually says whether they're suspect or not of motor difficulties. The other piece that equally they must fulfill in order to be included is that they can't be receiving public rehabilitation services for their motor difficulties. Next slide, please. I'm going to get you to move to the next one, just so we have some time to chat. So some of the things that we needed to do for this larger study was indeed to actually create a few things, which is sort of where I'm going to kind of focus the rest of the presentation. One was a web-based platform that met all privacy legislation in Quebec, that was dependable, and that where we could put all of the pieces of our intervention. So that being video, web-based video for interactions with the therapist, where we could have a chat function, a forum between parents, resources. So we all wanted this housed in the same place. And equally, there was some training we needed to provide to the therapists who were actually going to be involved in this intervention. So next slide, please, and I'll give you a little bit of a snapshot of what the forum actually looks like. So I really wanted to be able to link to the forum live for you to be able to see how this all kind of works. We were lucky enough, if you can call it luck, I suppose, is that we launched the study about 2 weeks ago, just before all the COVID-19 stuff ramped up. So we are actually live, and there's actually patients being recruited and patients who are being seen on the platform right now. So because of the private information, I can't link to it, but I did some screenshots in the hope to kind of give you the best view of what this actually looks like. So we first have the overview tab, and if we go to the next slide, you'll see what happens when we kind of click on it. So the patient sees a bunch of information. So they can enter their profile picture, as well as they see who is the assigned clinician to them. So they each have either access to a prime therapist, so either a physiotherapist or an occupational therapist. That's based on their availability, but equally on their goals. And their goals you see outlined there on the bottom of the screen. And then any other information they want to share with us, including, you know, the name they want to use on the parent forum, which could be their own name or a pseudonym. So that's sort of what the overview tab would look like. If we go to the next slide, you will see that equally we set appointments for them. So it's based on the calendar that you see, and when there's a little red dot, it tells them by the number on the date, it tells them that they have an appointment and who it's with, as well as where to connect or what to press in order to connect to a video call. So within the protocol, the families meet with the therapist for 30-minute appointments based on their goals. And we do so about every 2 weeks for the first 3 months. And then they have access to the therapist on an as-needs basis for the next 9 months. So they're enrolled in the study for 12 months. Okay. So then if we go to the next slide, So equally, as I mentioned, they have access to a parent forum, which is moderated by the physiotherapist and the OT that are equally the therapists in this study. They can access the forum as many times as they want. And again, it's question answer. So you'll see some of the questions that are appearing now. And so they can basically ask just about anything. And we are encouraging the parents to answer as many questions. There's still a 5-year span, so the parents have developed some experience over time. So potentially a parent of an 8-year-old has some interesting tips and tricks for a parent of a 3-year-old because they've gone through some of that information. Equally, the therapists are moderating that and can add information if there's not enough exchange or if we want to correct something or something along those lines. Right next to that tab, you will see resources. And again, this is resources that are typically online information. So they can be links, they can be videos, they can be basically anything that's flexible and accessible. And in particular, in this study, they're all, we're trying to put them all in French to ease the understanding. But depending on what the subject will be. And the forum is driving, to a certain extent, the subject of the resources. So if we have a lot of questions around something, we're going to look for resources that potentially we can add to that to meet the needs of the families. So if you go to the next slide. Perfect. I think there's a little delay getting across the country with changing the slides. So we equally, like, Facebook and a number of those things, have a messenger tab where the therapist can send some information to the patient and the patient can send it to the therapist. So this is pretty direct, only patient and therapist, not patient to, or participant to participant. Okay. And last but not least, we have the tab About Us, which reminds the families about what the study's about and what they signed up for, should they might wonder, how long am I in this? So that is the intervention arm, has access to all, so this platform. As I mentioned, it's a randomized controlled trial or pragmatic trial. So, which means that there is a group who's randomized to do this, and then there's a group who get technically nothing, or they get treatment as usual, which could mean at some point they access public service rehab services, but otherwise you don't get anything from the actual study. Okay, we can move on to the next slide. So I guess the question becomes, so what type or how are we going to provide intervention from a web-based perspective to these families? So we can't touch the child. And so how are we doing this? So we're adopting a coaching approach, which is gaining more and more momentum within childhood disabilities. But the coaching approach is really an umbrella term where a whole bunch of different interventions actually can reside. But there are some important components within that. And so on the slide in front of you, you kind of see two possibilities of parent or of coaching in disability and pediatric rehab. So, and they're all around who are the people on the team. So there's two different types of teams. So you could have a coaching situation where you have the child, the parent, and the coach or the therapist. Equally, you can have only the parent and the coach or the therapist. So we're adopting a little bit of, or a big bit of a mixed model, in that for the most part, our thought is we'll have primarily the therapist and the parent. However, if need be, for the therapist to better understand, or if the parent really wants to show a strategy that potentially is not working, the child would be invited into the session. Equally, if the parent wants to invite one of the partners within the child's community, so that be a teacher, a phys ed teacher, a sporting coach, anything along those lines, they equally can invite them to be a part of the team. Equally, we can have different foci for the intervention. As we mentioned, it is all based on goals. And in coaching interventions, you can have it be child-focused, so basically on strategies to address the concerns or the child's goals. Equally, it can be parent-focused, so if the parent is feeling really stressed, they want to learn advocacy skills, it's very parent-focused, we could do that. And we're adopting a bit of a mixed model where it could be child, it could be parent, all depending on the needs of the family. So if we move to the next slide, which will be the last slide and probably difficult for you to see, but really coaching types of approaches are meant to strengthen the family member's capacity to support their child in the child's development within the context of everyday routine. So we're looking at kind of an ecological model of where's the child, where's the goal set, does its parent want the goal to transfer from home to school, from school to home, from school to community, etc. So really looking at, so what are those daily routines, what is the context? We're going to be as least directive as we can be in really fostering problem solving amongst families, as opposed to telling them what to do, unless that is what they want and that will meet the need. We're going to be very focused on functional activity and participation in daily life, and really empowering families to develop their own capacity and skills and be as and help them be reflective, so that hopefully that will continue to help them manage their child's condition over time. So as I mentioned, we are 2 weeks into this latest study. I'm providing intervention to my very first client this evening. So looking forward to seeing how that goes. So I wanted to keep definitely a few minutes for any questions. So if you go to, just skip the next slide. Yes, perfect. So any questions on anything I presented?
Hi, Karen, it's Holly. I think this is amazing, and I'm so excited to see how this is all coming to fruition and looks so good. I have a few questions. One of them is, I know there's not a lot of information in the literature about frequency and duration for intervention services for kids with DCD, and I appreciate that you're not really doing therapy, you're doing a more coaching model, but how did you guys decide about the appointments every 2 weeks for 30 minutes? And are they sort of standing appointments for that for a few months, or do the parents, can they just sign up for them if they want them intermittently? And how did you decide on that length of time and amount of time?
So basically it was a little focused on kind of bringing them to the platform, and higher intensity earlier on. So it is every 2 weeks for the first 3 months, or 12 weeks, so 6 actual visits. The every 2 weeks was based on the coaching model literature and giving them time to trial out a couple of things, a couple of suggestions or a couple of solutions they'd come up with a few times, and make some observations in order to be able to bring back those observations so we could work with those observations and potentially reflect on them. So that's how that was decided. recognizing that if a family can't come or can't meet every 2 weeks, or the day has to change, part of this intervention, as I mentioned, is really grounded in the needs of the families, because that is what we heard from the previous studies. And so we're willing to be flexible on that. So, but we're trying to really do that upfront, regular appointment, just to get them used to the platform, prior to, and after 3 months, we can have a discussion of, do they want to continue every 2 weeks? Did we meet, or do they feel like they're well on their way, etc. So that's sort of how that came about. Holly?
Okay, yeah, that makes sense. Thanks, Karen. I have another question. So like Sylvia said, we were just going through the process of starting to take more clients on for Skype sessions and getting a little bit of education on making that transition a little bit easier for us right now with not being able to see as many clients face-to-face. And in one of our Skype sessions, and if this PT is listening, I'm not calling you out, because I was like, yeah, that's a good point, because the PT was like, well, I can see how Skype would work really great for OT and SLP, but not so much for PT. And I think this is a really good example of how it can work. And I'm just wondering what the other PTs out there are thinking about that.
This is Candace. May I comment on that?
It's Holly, and I'll say yes.
Okay.
Of course.
So my thought about it actually, with regards to PTs not having hands-on, it's a beautiful opportunity to really be coaching the parents, and it forces you not to jump in there, but to guide them through their, guide them, coach them with their skills. So I think it's lovely. That's one comment I have. And then can I ask a question?
Yes, go ahead.
So I was wondering, Karen, if you guys are capturing all those touch points along the way. You have your every 2 weeks half-hour sessions that are available in the first 3 months, but the online chats and say those directly with the therapist and so on, just to get a sense of those folks that really, richly dig into the platform and how that impacts the results, their perceived knowledge and satisfaction and so on.
Great to hear your voice, Candace.
Yeah, likewise.
We work together at Alberta Children's Hospital. So, yes. So the wonderful thing about about web platforms is there is this thing called a back end, and so with platforms, as you potentially, if we look at sort of Facebook or Instagram, behind all of the gentle stuff that we see, so the screen, is that there's data collected behind that. So, the data collected is, did I respect the 30 minutes that I had, or did we go over most of the time as a therapist? How many times did the therapist go on, or how many times did the parent go on? How many times did they post a question? How many times did they respond? So we're able to track all of that information through the actual platform. And so it, some of the stats I was giving you with regards to the physios and how we determined that only 74% of them used the platform, right. That was all that same data, who posted versus who didn't. What was the length of time they actually spent? How many visits did they come? So that is not, so we don't need to calculate all that by just counting. That's all captured in within the program that's actually set up.
Because it'd be so interesting to see if the family's self-perception of knowledge or their confidence is low, and then if that's correlated to how many touch points they have and the duration, and yeah, it's awesome stuff. Thank you for doing this.
Both groups have a large number of questionnaires that they are filling out at prior to starting the intervention, 3, 6, and 12 months. And so all related to, of course, our question of do we increase, the parent self-efficacy, and really those primary objectives that we have for this study. So it's going to be certainly very interesting to actually to look at it in probably 18 months' time.
Super, thank you.
Any other questions?
Hi, I have a question.
Sure.
Can you hear me? Yep, thank you. I'm a private OT in Calgary, and I have a contract with some kindergarten kids, and as of today, I've been asked to finish up with them through telehealth. So this is timely, so I'm just trying to figure out how I'm going to reach out to the parents, and I could see the telehealth sessions with coaching and speaking to the parents. I was wondering what you thought about with some of my DCD clients that I see that I have ongoing, usually hands-on one-to-one sessions with. If you thought through web-based, I could try something like backward chaining and doing shoelace tying.
Mm-hmm.
Have you tried any of those type of things online, and have you had any success?
I can see them working. I have not tried them yet, although that is one of the goals of the person I'm seeing this afternoon. So I can keep you updated on that. The only thing I would check, and it was interesting, I was having some discussions today, is just making sure that, we are lucky enough to have launched this project and have a web-based platform that, we know is completely secure. And it's just ensuring that you follow your college guidelines around what telerehab and what you must put in place for telerehab in order to be able to use it as an ongoing intervention. I just mentioned that I know they're being, in particular in this time, sort of a little bit more flexible with some of the guidelines they've put in place. But just have a look at, and most of the colleges actually have guidelines on telehealth. So just consult those.
Okay, thank you.
Is there some background noise happening? If people could mute. Or someone's at the circus.
Karen, it's Sylvie here. Could you give us an example of maybe one of those child-based goals that you've either heard one of the therapists working on with a family or yourself?
So, I can certainly do that. Give me 2 seconds here, and I'll actually. So how we set the goals for the child. It's similar to how we would do it clinically, in that it is, we use the COPM. So as part of the admission to the actual to the study, they all did a telephone interview with some of our coordinators, our study coordinators, who are our students, OT and PT students, and they went through the COPM. And so that's basically how their goals were established. So very typical goal. So if I think of one of my little mites, it's going to be what they want to work on is, there's going to be bicycle riding. I've got some shoelace tying to prepare a bowl of cereal without making a mess. To be able to, let me see, check a few other ones. To be able to get dressed independently. So it's kind of like to be able to do up a zipper, to be able to catch a ball, to be able to throw a ball. So they're really all over the place.
And have you tried using some of the co-op strategies, or how are you addressing some of those goals?
So as I said, I'm seeing my very first patient after this session. So my plan is to see My plan is to see what have the parents tried, what strategies have they used, do they have any other children, have they tried different strategies with them, and really sort of look at, so what are the possibilities that we can look at? Can they ride a 3-wheel bike as opposed to just 2-wheel bike? You know, some of those questions that we do from an intervention perspective, even when they're actually in front of us, and to see what the success rate is with regards to that, and then and see what strategies we come up with together, what materials they have available. Because it's you know, it's interesting because it's going to be all what they have available, not necessarily the piece of equipment typically I would have when I'm in the hospital and, you know, or in a rehab center and I have these different things available. So, you know, yes, potentially co-op could work with them, but I would certainly walk them much more through the steps with questions as opposed to, you know, actually be concrete with the strategy to start off with, using the coaching model, of course.
Mm-hmm. Mm-hmm. Does anyone else have any questions?
Karen, this is Candace again. I have another question regarding the behavior change in the parents, because if it's based on questionnaires, and certainly the COPM will reflect how they feel, how satisfied they feel about the changes. But are you guys doing any, do the parents, are they, through the videoing, are you able to see how the parents are interacting differently with their children, and if those interactions are coded to see the changes, the behavior, the real-time behavior changes?
So that observation is not part of the outcomes, Candace. It would be great if we could, but it currently, unless we actually ask for it from an intervention perspective, it's not part of what we're looking at currently as an outcome.
Yeah, sure. Yeah, it's just so...
Unless, you know, they actually discuss or we ask questions around that behavior change. So how are you seeing that? Or, you know, those sorts of questions, which, again, much more intervention-wise than you know, outcomes. That being said, yeah, go ahead.
Sorry, I was just going to say, with the coaching, that, you know, you could see that natural outflow of how, say, if you had a baseline, you know, of them trying it on their own with their own strategies prior to being involved in this format, and then seeing them later integrate the knowledge, the coaching, all those, you know, the treatment kind of piece that you guys are implementing, and then I'm sure you would recognize, hey, you know, they're adjusting this, they're providing this praise, or whatever, all those components that you're supporting in the parents.
Yeah, and it would be a great way to potentially do it. Currently, it's not how this study is structured. Potentially, the next one might look a little bit more deeply at that. The other piece I will add is we are doing interviews with the families at the end to capture, you know, a variety of information that we may not be getting or not in enough depth or breadth with the questionnaires. So potentially examples of what the behavior change is as opposed to observations may be something that we touch on there. The interview guide is not quite done yet, so I can't say for sure, but certainly something that could be a potential.
Yeah, it's just stepwise, right? So great.
Yeah.
I'm sure there's probably lots more questions out there, Karen, but our time has come to an end. I think this presentation has been extremely timely, Karen, and I think that you've really given us some ideas to think about what we need to make that online interaction successful and positive, and it's given us some ideas on how we can start providing it. I think it's really going to excite us on how we might be able to embark on this new way of providing services. And I think the other strength, sorry, go ahead.
I was just going to say, and I'm embarking on this too. So, if anybody has any questions or anything like that, please feel free to reach out. Equally, one of my interests, and I'll be probably in contact with you, Holly and Sylvia, that, looking at, so what does it look to implement something like this in Alberta? This is all implemented in Quebec. We don't know how it works in different healthcare systems just yet. So it'll be really interesting as we move forward to have some of those discussions, potentially see what you guys ran up against, what we ran up against, potentially problem solve together, and move this forward as a potential for, not just COVID-19, but how we actually practice.
Yeah, and I think the cost effectiveness, and not only for us as a service provider, but also for families.
Yeah, and it's interesting. I'm not sure, and I didn't point to it only to get through the presentation, but one of the things we eliminated or switched when we were looking at that suspect DCD or suspect motor function is you'll notice that in the feasibility study, we were actually bringing them in to do movement ABCs. And that's how it was established whether or not they had a delay, and we've moved to an online DCD, the DCDQ, and that was because we were told by parents even that one visit was sometimes so hard to schedule, the face-to-face, that it just made it too hard to access service. So which I found fascinating.
Anyway, and the other great strength I see is that this method really allows the parent and the child to drive the intervention, which I think is very exciting.
Absolutely.
So anyway, thank you so much, Karen, for taking time. I know how much time it takes to get something like this together, and thanks for sharing your knowledge. Stay well.
Anytime, and thanks for the invite, and stay healthy, everyone.
Thank you.
Good luck.
All right.
Thanks, Karen.
Have a good afternoon, everyone.